officially kick things off. So we're at 115 participants. Amazing. Thank you for everyone who is joining us here this afternoon, this evening, depending on where you are located. So today's workshop, Learning Together, Sharing Best Practice Standards. So as Arit was saying, we are going to have this hopefully be an open dialogue, a discussion. But before we get into things, I'll do some introductions and set some kind of ground rules for the webinar. And so to kick things off, my name is Jennifer Winter, the owner of Pedicare Professional Foot Care Instruments Limited, located in British Columbia. And I see I have quite a few fellow BCers here today, which is great. So if you don't know us, we are a supplier of instruments, equipment, and supplies for foot care, and we've been at that since 2006. And then joining us, we're a panel of speakers. I'm mostly going to host and moderate today's session, and then we have Arit Van Ham from toenails joining and sharing her expertise with fungal nail treatment and of course the technology of toenails, and Tanis Sorge, and Arit is in Ontario right now, and we have Tanis Sorge who's also in BC, and she is the owner of PetEd and a foot care nurse. Of course, most of you on this call probably already know Tanis, whether it's through conference attendees, taking part in her education, and so she is here as well to share her expertise in treating fungal nails. So we are setting this up as a peer-to-peer learning experience, trying to share knowledge with everyone who's attending. And we did use the term best practices. And so we wanted to clarify from the outset, when we say best practices, we're not talking about regulatory standards. We're talking about the best practices for the treatment of fungal nails. It's not that this is something that is going to be found in an official document or a regulatory document, but we're here to share best practice standards that can be used within your foot care practice as you have clients that you're treating that have fungal nails. And so the length of this webinar, I expect we're probably around an hour and a half, depending on the amount of discussion and interaction that we have. And what we'll do is we have a number of questions that we have worked on that cover a variety of topics. And so we're going to go through those questions one by one and present some information, and then happily please submit your questions and we can address those questions within each of those individual segments. And I think also one thing I guess we should mention, even though we are going to have this be an open discussion, it's probably best to have your mics turned off until you're ready to ask a question, just so we don't have too much background noise that could be happening on your end. So without further ado, we will kick things off and we will get right into things here. So to start off, we're going to get into our first question here. And so as we go through these, for the first couple of questions, we're going to have Arit provide some information for everyone. And then, as I said, please do ask questions, and we want to make this a collaborative session for everyone. So to jump right into things, the first question we're going to talk about is, what can the visual appearance of the nail tell us? So as you have your clients that you're treating and you're looking at these nails maybe for the first time, what can you learn just from looking at the visual appearance of the nails?
Okay, so I have a few slides to answer this question and also the next one. So can you show quick? Okay, never mind. Okay, so I will answer this question. Basically, I wanted to share a very good information that was not created by toenails, but it was written a very good piece of literature about onychomycosis severity index, how to look at the nail and how to assess the severity. We used it all across our clinical studies, and now we are trying to share it with our partner clinics because we feel that it's really important to assess the severity, and from that to know the prognosis and to know how many treatments are needed, and also to communicate that with the patient. So I'm going to share my screen here. So this is David. He is our clinician helping us in Hamilton, Ontario with our clinical studies. Beside him is his assistant. Someone lately told me through the training that we provide that the assistant needs a sandwich. So we start with this and we move forward to what can visual appearance of the nail tell us. So actually by looking at this for example, it's important to try to assess where the infection started from. The reason being is you can you can know, for example, when tennis will probably talk about debridement, but if it starts from the distal area, so the proximal area is healthy and there is no need to touch it too much. However, it's important to debride closer to the edge between the two of them, that just to kind of create a firewall, we call it. So to try to stop the fungus from getting to the matrix. So so this is distal infection. This is wide superficial infection. This is less common, but it's a proximal infection. And by looking at this, normally the infections, 70% of the infection are caused by dermatophytes. A candida infection looks a bit different. So this is, it's not that it's affect the treatment, but it's kind of not important to know. Often or many cases start with tinea pedis, so skin fungal infection. So next slide, this is the actually scoring, the onychomycosis severity scoring. And it actually has 4 components. And the reason is the people that wrote this journal, the paper, actually found that when they share a picture between clinicians, each one assess the severity differently. And it's really important to kind of have a baseline because, for example, in some cases, clinician, when it's 50% involvement, they will say that it's severe case, and some will say that it's moderate. So for this reason, it was important to come up with an index. So the index looks at the total area of infection. So if it's distally between 0 to 25, it's a score 1. If it's between 25 to 50, it's 2 scores. And 3 scores, and 100% between 75 to 100, it's 4. And then the other index is proximity. So if it's distally, it's a score 1. If all the lanula is involved, the prognosis there, it can, for example, using TOEFX, it can help, but it will take longer. So it's a score 5, and you basically multiply them. Another 2 factors are thickness. So if there is accumulation of keratin and the thickness is more than 2 millimeters, so it's another 10 points. And another one, a big one, is patches, which I'm going to touch upon soon. So for example, looking at those pictures, so the last one here, it's of course, it's a severe case, but for example, this one that the score is 15, so it's a moderate case. However, the area is less than 10%. So one would have say that it's a mild case, but not, it's a moderate case because it's very close to the proximal area. So this is the area of involvement where we talked about. It's divided to 4 sections. Then the proximity to the matrix, And this is an important slide or important topic that I wanted to discuss about patches. So just a second. So strikes are often near the lateral nail fold. It's important to know not to confuse them with onycholysis, because onycholysis, of course, it's not related to, often not related to onychomycosis. So for example, these are few examples of patches. So this is one example. The other one is here. You can see a patch here and a patch here. And here you can see lines. Often patches are yellow, and sometimes they are white and opaque, and they are actually indications of high accumulation of fungus, which means that those areas are harder to treat and needs attention as debridement, and to make sure that the penetration of the treatment is good in those areas. So those patches are actually, you can call them accumulation of fungus or masses of fungus, and sometimes even biofilm. And these are actually population or communities that get together and surrounded by extracellular matrix. So actually those fungus have another layer of matrix, which makes those areas really harder to penetrate. These are another example of a few patches that probably Tennis is going to touch upon soon. So this is a long answer to a short question. Back to you, Jennifer.
That's great, Arit. Thank you for sharing. I'm going to just share my screen here again for a moment. There was a little bit of a lull where I think people were not seeing the slides. So if anyone is still having trouble seeing the slides, please put that in the question and answer. But I believe that was just a momentary blip there for a second when the slides weren't showing up. So I'm going to share my slide again as we head into... Oh, we may have gone one ahead there. So for you've really covered both of these questions with the slides that you have shown. Tanis, did you want to add in anything else at this point?
No, I don't think so, because we're going to talk about that when the pictures come up.
Perfect. Okay, that sounds great. And so then the next question is, but is it always fungus? And Arit, did you want to add more about that?
I can jump in.
Sure.
Like here.
That would be great.
Yeah. So what I do when I'm looking at this is I kind of want to break this question down into a couple of different areas. So there are things that put clients at higher risk, and there are some things that are a differential diagnosis. So it looks like fungus, but maybe it's not fungus. So like everything in nursing, it always comes down to doing a really good assessment and putting that, in your different hat on to be a really good investigator. So getting their client history and asking lots and lots of questions, not just what we're seeing, but also what the client is telling us. So things we want to look at are, so things that put clients at higher risk would be things that like immune compromise. So people with diabetes, HIV, maybe they got vascular disease, smoking, which of course falls back into poor circulation. Maybe they have a history of hyperhidrosis, so they tend to sweat, excessive sweating. That is just going to create an environment that's going to put them at a higher risk. Then there's the big one, injury and trauma. So that's a really tough one, because we can have people who have injury over here, and then we can have people that have fungal infection, So this will look like a fungal infection, but it's really trauma. And then we have this one that's really a fungal infection. And then we can have a fungal infection and a trauma. So a trauma will put somebody at a higher risk of having a fungal infection, or it just might be a trauma. So that's a hard one. You want to ask, have they had any history of a trauma that they know of, or maybe you can see visual effects of a trauma. So maybe it's a fungal bleed that's there, or there's a visible trauma. Other things is asymmetrical gait. So lots and lots of our clients have asymmetrical gait, right? Like most of them coming in walkers and wheelchairs. They are waiting on hip or knee replacements. They got old injuries or just pain. So you go, geez, why asymmetrical gait? Why is that such a big deal? Well, it's that repetitive trauma. So if their gait isn't even, they have that repetitive trauma. And like we were just talking about trauma is going to put them at an increased risk. So, and talking about that asymmetrical gait, so I have a little story about my mom. My mom is 80 years old and she's a super senior. She just turned 80. We took her skiing. She made me run the marathon, and and she came second in her age group. Like she is truly a super senior. Walks 10 to 12 kilometers a day. But if you asked her medical history, she would say, "Oh, I'm super healthy," and that's true. But she has this completely wonky asymmetrical gait. And if you dove a little bit deeper into that, you would actually find out that she actually had, oh geez, now I've lost the word. Polio, thank you. So she had polio. So that's why she's got this wonky gait. She's got all kinds of structural deformities to her feet. She's got cocked toes. Now I offload them super good. So keep her walking. But if you hadn't asked those questions about why her gait was so off, that is putting her at a higher risk for having a fungal infection. And the reason we want to know that is if we're wanting to treat a toenail and we're trying to determine, is it fungus? Is it always fungus? The easy answer is no, it's not always fungus, but we just have to take that really great history and find out. So the other question that I would also be asking is there any, I would be looking to see if there's any tinea pedis, but also if there's a history of tinea pedis, because of course we know that fungal infection will move back and forth between the skin and nail. So that's a really good piece of information that we need as well. I also want to know, what did they do for a living? If they're retired, were they in, work construction? Were they in steel toe shoes? Were they in rubber boots? Were they working inside, outside? What type of sporting activities did they do? What are their hobbies? Because all of that can play a part in putting them at that higher or lower risk factor for onychomycosis, which just helps us in our little investigation as to whether or not we're going to lean towards onychomycosis or possibly lean towards that this is not truly a fungal infection. So differential diagnosis, we look at, again, trauma, like we talked about, without fungal infection. Bacterial infections, things like Pseudomonas, that is another one that will present as thickened and discolored. Autoimmune, we already mentioned that. Subungual verruca or periungual verruca, so maybe it's a wart underneath there. I don't know if anybody's had that before. The first time I saw that, I didn't know what it was, but it was distorting the nail. There was, it was discolored. But I actually wouldn't have known the first time I saw it that it was actually verruca that was underneath. So that's a differential diagnosis. Idiopathic onycholysis. So there's separation, but we don't really know why it's separating. And carcinoma and melanoma. So that's another one. Early in my practice, I actually had a client, and I mean, very early in my practice, like probably within the first few months, I had a fellow who came in and he had an injury on his toe. He said he didn't remember having it injured. He went to the doctor about it. The doctor said that it was a trauma. It was a fungal. It was a trauma. Next time I saw the client, it was still there. He saw the doctor again. The doctor now said it's a fungal infection. And so the next time I saw him, it hadn't moved. It was exactly the same. So if we have a trauma, so say this is the center of the nail, we have a trauma. If it's a trauma, it's going to grow out. If it's a fungal infection, it tends to grow down and head towards the matrix. It didn't do either. It was staying center in the nail, distorting, color just was changed. I looked at it. I had no clue what it was. And so I sent them back to the doctor. They ended up removing the nail, and it was actually a very aggressive cancerous tumor. And that was a fellow I saw 21 years ago. I have seen him every 6 weeks for 21 years.
Wow.
So he's a lifer. So all that to say that it's not always a fungal infection. And so you really have to dig deep on that. So the super common one that often gets mixed up with fungal infection is eczema and psoriasis. So if you see pitting, little pock marks in there, be a little bit suspicious and then start asking. So I have two stories actually about this study that I did with iRich. So I'm trying to think now. I was trying to think earlier today, about a year and a half ago, we started this, 2 years ago, something like that. So I did a study for TOEFX, and so there was a screening tool that we did because we wanted to make sure that we were trying to get people that did have true onychomycosis and not that it was actually a differential diagnosis. So they had to fill out a health screen and get some history on there. And of course, anybody who had eczema or psoriasis was not entered into the study. So when the study first started, we're progressing, we're early into the study, so you're not really seeing a lot of change yet. But in all honesty, I think because of the debridement piece, the nails were actually looking better right off the bat. So about halfway through the study, we had 2 people that just were not progressing. And so we had meetings about it, trying to figure it out. I'd go back, ask them a bunch of questions, and we just couldn't figure it out. Then the heat dome hit in BC. So it was extremely hot, and not everybody in BC has air conditioning. We do now, but we didn't then. And the fellow came in, and he comes in, and again, I'm asking him history and going through everything. And then I looked up and I saw something on his hand, and I said, "Can I see your hands?" So he puts his hands out for me, and I go, "What is that?" So he says, "Oh, I broke out. I haven't had this since I was a kid." I said, "Did you have psoriasis as a kid?" "Yeah, but I hadn't had it in like 50 some years, so I didn't mark it down." So we're going, okay, maybe this isn't a fungal infection. Maybe it's actually psoriasis. Then my second lady came in who also was not progressing, but it was extremely obvious. She had it along her hairline. She had it between her fingers. She had it in her elbow creases, and she had broken out. Now, I don't know why in the heat dome, but both of them had broken out when they hadn't with 50 plus years. So again, just really asking about that. If not only the pitting, but if you see sort of lines going across the nail, be a little bit suspicious with that. The tougher one with psoriasis is that they start to get a little bit of separation and the discoloration. Well, I mean, that happens with lots of things, trauma and with fungal infection. But the one thing that is different is that usually the fungal infection, if we have separation, it tends to be on the near the free edge, where with psoriasis, it can be anywhere on the nail plate. So if it's anywhere other than the free edge, be a little bit more suspicious as well. And of course, chronic nail polish use and damage. So yeah, all that said is that taking that really great history is super, super important. And not only are we gathering information as to whether or not this is going to be helpful for them, but we're also, it's going to help us with education and providing realistic expectations for treatment if they end up proceeding that way. I think that's it for me.
We do have a few questions that have come in. And one of them was an attendee, a participant who was hoping maybe to share a couple pictures that they have of a client that we might be able to speak to. And then the second one was, do you take a fungal sample and send it to a lab for confirmation if you're unsure of whether or not it's fungus?
Yeah, that's a really good question. I'm going to let Irit talk about that as well, but I'll just say from my practice here in BC, often there isn't a whole lot of interest. And I wondered, okay, so why is that? Why are the GPs not wanting to send samples? Do we get, I've had a handful of them where the clients come in with their little CNS bottle and their little black paper and the instruction sheet on how to do this. And of course, we do that for them. But there isn't a whole lot of interest. And so I was actually talking to my girlfriend, who's a microbiologist, and she said, I don't know why you guys send these things. It's so hard to grow in the lab. It's extremely difficult for us. So, and I'll let Irit give her opinion on this, but sort of from what I hear from physicians here in BC is that if it comes back fungal, it's fungal. If it comes back not fungal, it's a negative result, then maybe it's positive, maybe it's negative. So, and very few people do the KOH testing here as well. So it's really how they present to the medical history is what I'm seeing here in BC. Irit, do you have anything to add?
Yeah, of course, it's my favorite topic. Jennifer, can you allow me to share for a second?
Absolutely.
So I will start saying about diagnostics. The standard diagnostics in Canada and I guess across the world for now is yes, culture and KOH. There is a big issue with culture in terms of the sensitivity is not sensitive, and as Tenny said, many samples come back false negative, and it's a huge concern. There are other and also it's not standardized between the labs in Canada. There are some labs that test it on a Petri dish, which is better. Some labs do the testing on a slant, which is less good. And because of that, in TOEFX, we realized that there is a gap, and we developed its own research still, but a very sensitive PCR, which basically you need 1 milligram of dust from the infected area, and you get the results in about 5 to 10 minutes. It's testing the DNA. We are doing its own research still. If you want to touch base with me, and I can share how to maybe approach us and we can help. So in terms of what's causing the infection, and so often it's dermatophytes, and dermatophyte is type of fungus that live off keratin. So they just need the nail, a protein, a humid and warm environment. Most of the cases are Trichophyton rubrum and Trichophyton melanogastritis, so it's about 70 to 80% of the cases, and also Candida, as I showed you before in one of the pictures. So 90% of the toenail infection and 50 to 75% of the fingernails infection are caused by dermatophytes. So the others are non-dermatophyte as Candida, as I said before. Probably tennis can add to what we see here, but these are two infections that caused by Trichophyton rubrum. So this is onychomycosis, and this is Tinea pedis. Often cases, it starts from the skin and migrates into the nail plate and to the nail bed. Tennis, you want to add something here maybe?
Well, I think that we have some slides coming up that we're going to talk about debridement, but I read you guys are planning at ToeFX to start testing for people, right? Is that correct?
Yes. Mm-hmm. Yeah.
And have you completed this study now, comparing how you're testing in comparison to taking it to somewhere like Life Labs?
Yes, we did. Yeah, the PCR that we have developed is much more sensitive. So we have managed to identify the many cases that were negative in the culture. So these are few example of, most of them are tinea pedis, but as Tani said, with involvement of sometimes other microbes. So here it's, for example, onychomycosis with secondary bacteria infection. Here you can see that it's 100% involvement of the nail plate. Here, this is what I was thinking, Tennis, that you can maybe talk about, but here you can see many cases. Sorry that it's a small picture, but one would have maybe confused some of those cases with onychomycosis, but sometimes by the nail is the nail picture, or a very good picture, if you take it even on your phone and zoom in, you can discover so much information. For example, number 2 here, maybe it's hard to see, but you see the pitting, which is, as Tani says, this is a psoriasis and not onychomycosis. For example, 6 is it's called spoon nail, so it's actually an indication of iron deficiency and not onychomycosis and others. Tani, something that caught your eye here?
Well, number 11 is another common one, the yellow nail.
Mm-hmm.
Which is very, very confusing. It's really difficult to tell the difference, but you have to be able to identify some of these things and then putting their history together as well. But ultimately, if the client is coming in and talking to you about it, I mean, are we going to get a completely accurate, or can we say definitively that it is a fungal infection? Most of the time, no. I mean, we just don't have access to be able to test, and some of the testing, like I was saying, is not actually that accurate at the moment. And so if the client is coming in and doing that and talking to you about it, it's bothering them, or they've seen the commercials and their families are after them to do something about this, then the client is willing often to say, okay, well, let's give it a go. Let's try and see if this is going to work. So, and if, again, we're going to talk about realistic expectations in a couple of minutes here, but if you are giving them the whole picture and saying, look, we can't say 100% that this is a fungal infection, but if you want to try, we're going to give it our best effort to make this successful for you, and we'll have to see what the end results are. But usually clients want to try. They want to at least do something, not just ignore it.
There are also a few questions that have come in through the Q&A that maybe we can address now. One of them was smell with the fungus. Is there any consistency there? Is that a definitive identifier of toenail fungus? What are your thoughts on that?
Well, I would say with some of them, there is definitely a smell. So I always use the analogy that it's kind of like walking onto the ward and you smell C. difficile. You don't have to wait for the result to come back to know that that's what it is. So, yes, in some cases, but not all the cases.
Okay. And then there was another question in regards to, you have 2 feet. One of them is perfectly normal, and then the other one is completely fungal. I guess in terms of the likelihood that it is actually going to be fungus if one foot is completely normal and the other one is fungal.
Yeah, do you want to deal with that, or do you want me to?
Sure, you can jump in and I can.
Okay, so that is fungus is a mystery with some parts of it, right? And so did it start with an injury and it spread to the other toes? That could be it, but often, in my opinion, the others probably have it. It's just that they're not showing it yet. So that's why all the nails are treated. We don't just treat the one that has it. The chances are the other ones have it as well. It's just that they're not presenting quite yet, in my opinion.
Exactly, I agree. So for example, with toenails treatment, we recommend, even if you see toenails that are infected, we recommend to treat all toenails.
Okay, that's great. Thank you. And then there were a couple questions that you've touched on this already in terms of the testing. There were questions in regards to the cost of testing, but I think, as you've both mentioned, sometimes it's more about access to testing versus cost. Is it covered by in some provinces, that testing?
No, it's covered by OHIP, but it needs to be to go through the family doctor or dermatologist. So it's by requisition.
Okay. I'm just quickly looking through. There's quite a few questions that have come in.
And I read it's actually very sad too, because most people that do go to the doctor to get tested, the doctors often don't want to do it. I have them where they've been told to wear nail.
So what was that?
Just wear nail polish.
Oh my gosh. Wow.
Which is just terrible.
Yeah.
And also also the sampling of the sampling for the diagnostics is very important to have the technique. So some of the physicians do not have the expertise, right? So.
Well, I don't think they have the equipment usually either, because how would they get dust? I mean, they can take a clipping, but I don't know how they would get any of the dust.
Mm-hmm.
There's a couple of questions here in terms of how you factor age into treating toenail fungus.
Oh, that's a tough one. I think it depends on the person, because I mean, if it was something that was going to damage their liver, I mean, you'd be taking that definitely more into account when you're looking at their age and other illnesses that they may have. But if there's no downside to using a product like ToeFX, then, I have people that are quite elderly that want it, they want it gone. They want to at least feel like they're doing something to treat it rather than just leaving it. And other people are like, yeah, it's fine. So yeah, I think it depends on the person. If there's no downside or any risk to them, which maybe you can speak to that a little bit better, but if there's no downside to it and they want to do it, I wouldn't deny somebody treatment due to age.
Yeah, for sure. There is no a risk or contraindication, any known contraindication with ToeFX. The prevalence of onychomycosis is much higher with older people. So in the general population, for example, is between 10 to 20% of the general population. With older people is around 50%. And in long-term care, for example, now we are doing a study, it's actually higher than 50%. The only thing when considering treating older people is the progress. It will progress, but it might be a bit slower than younger people.
Mhm.
Okay.
But
There are a number.
that again is setting realistic expectations for that client.
Exactly what I wanted. Yes.
Yes, and we will get into that. There's also quite a few questions coming in about other treatment options, and we do have a question coming up about that as well. So for those of you that are waiting on responses in regards to other treatment options, we will respond to that shortly when we get to that section. So I think that covers most of the questions that are here related to where we're at this point in the presentation. Written, Tanis, was there anything else you wanted to add before we moved on to the next question?
No, I don't think so.
Okay, I will go back and share my screen here. All right, can you see the slide? But is it always fungus?
Yes.
Perfect. Okay. So why the main reason we're here? What are the best practices when treating a client with fungal nails? Of course, some of this has already been talked about, but Tanis has some slides here and content to share related to best practice standards. And again, as we said at the beginning, it's not about best practice standards from a regulatory standpoint. It's talking about what are the best approaches to take when treating fungal nails within your foot care practice. So
basically, what can we do for to give us the best chance for success?
Best outcome, yes.
Okay,
you want me to move on to the first slide?
Yeah, if we could, that'd be great. So this is kind of a mean slide, actually, because it definitely looks like some trauma here on top of everything. So after I put this in, I thought, yeah, this was more sort of, this is a tricky one when you can see a trauma and also something else going on here. And that was more to show, okay, you got to put that hat on and do an investigation a little bit more. But I'm just going to have you pop to the next one because it's the same foot, but I just wanted to show that, to have you advance one slide there, Jennifer. Perfect. So when we are treating, so if somebody wants to treat the fungal infection, it is super important to debride the area. So we want to decrease that fungal load and take it down as much as we safely can. Now, I do want to clarify the picture on the right here has not been finished. I get yakking, if you can imagine, and I didn't end up taking a final picture on this, so then I would smooth all this out. But if the client is wanting some treatment, or they were prepping the foot for TOFX or any treatment, we want to remove as much of that fungal, visible fungal or damaged nail as possible and decrease that fungal load. So here's just sort of showing that before and after. And I know it seems a little bit graphic on there, but we just wanted to set them up for success. And I had to sort of laugh. So this client here was going to on holiday, and it's a this person wanted to was a little nervous about having the nail taken down and what it would look like, and I had to break it to him that it doesn't actually look good the way it is. So, but it ultimately it's their decision. So if we give them all the information, look, the best chance of success is getting this removed and then treating it. But ultimately they can make the decision. And so anyways, he ultimately decided to actually do this and have it all taken down. And we're just gonna look at the next slide there, Jennifer. So these, yeah, this one here. So I want to talk a little bit about this one. So I'm just trying to think what I called that. I think he called patches. That's what you call them. So it's kind of funny because I have my own little term. It's not a technical term. It's just my own little way of talking about it. The picture on the left here, I call them oil patches. So they're oil patches or oil stains or whatnot. So you want to remove those. You want to take it right down. And I apologize, I don't have an after one, but I wanted to show you the how I call it the race for the root. So they streak down the nail, heading to that matrix. And like I was talking about, then this is bumping them up in their category when we're determining how much involvement. The closer it gets to the matrix, the more difficult it is to treat and the longer that it's going to take. So the picture on the right here, so this is a presentation that we often see. And so sort of where Jennifer had that cursor, you can just barely see there, those two darker spots. In the picture, it actually looks like it's bleeding, but it's not. That was not blood. But that, again, needs to be all cleared out. So when we're debriding, usually there's sort of a line. If you really look, you can sort of see a line, and you need to take all of that out of there. So I'll just have you go, Jennifer, to the next one. So here I remembered to take all three photos. So here we have the before on the far left-hand side of the screen. As I started to debride, I'm just showing you here, it's completely crumbling and falling apart. And then my finished product is on the right. Now we're ready to treat this nail. So this is what I call prepping the nail. I'm getting it all prepared for the treatment, decreasing that fungal load. And honestly, it looks better than when he came in anyways. And so they're happy. And the treatment is going to be much more effective. So they're going to, if I'm giving them the best shot that they possibly can have here. So I'll just have you pop to the next one there. So this is somebody who was in the study. So they've got the oil streaks or oil patches. And so this is, unfortunately, I took the picture partway through debriding on the right-hand side here. And then I stopped. I did finish this off and did a little cleanup just so that there's no jagged areas on the right-hand one. But this is just showing you that when we're doing the treatment, it's not always going to be perfectly straight across the line to have that, nice finished edge. If they're wanting to treat it, we've got to remove that fungal load as much as we possibly can. And again, that is part of giving the client expectations. So the expectation if we're going to treat this is we got to remove that, and it's not going to be a pretty line going across. And they're like, well, it's not nice anyways. So usually they're totally fine with that. But ultimately, like I said, they can make the decision as to whether or not they do that or not. So I cannot emphasize enough how important debridement is when treating a fungal infection. And the question back to best practices when treating it for the best outcomes is also giving the client homework. So I say, look, we're a team. I got my part, you've got your part. And when they go home, if they're full buy-in, they want to do everything they possibly can, then that's when we discuss with them all the things that they need to do to decrease and create an environment that is not conducive to fungal infection. So clean socks, wash your socks frequently, change your shoes, make sure that your shoes aren't damp, pull up the insole in your shoes so that they dry really well, spray with an antifungal, spray your shower, change your sheets more frequently, wash your towels more frequently. If you have athlete's foot or teniapetus, you want to make sure that you treat it right away. Like you've got to get on that. If that breaks out, you've got to get on it right away. And if they're full in, if these clients are coming to you, they already have a buy-in. They already want to treat it. So how I explain it to the client is, we're a team. What I like about ToeFX is I don't have to rely on the client if they do their homework, great. But even if they don't do their homework, I don't have to rely on them taking a pill, or painting something on, or going and getting blood work done to make sure their liver functions are okay. I don't have to rely on any of that because the application is on me. What the client has to do is the client has to show up on their scheduled times, and obviously a financial commitment to this as well. So yeah, I think in talking about best practice, Irene, is there anything else that
this was taking this is with ToeFX, right?
That's right. Yeah.
Yeah.
Oh, yeah. So we should explain that's what the blue is. So the blue color is the formula. So oh, and I was also going to mention too. So when clients, I mean, I'm sure you guys have this all the time, is that when they talk about their thickened nails, they talk about them being so hard. What they don't realize is that they're very soft underneath. And so I don't know if you guys can sort of see it here, but normally it's 3 tight layers, super tight together, right? Compacted, a nice healthy nail. So when it's a fungal infection is involved, we have all these loose layers, right, on top of each other. And they can't see from this side of their nail. They only see it from this side. So they can't see that. And if you kind of feel like there isn't buy-in to the debridement piece of it, and they can't, do the yoga move to look at the bottom of their foot and to look at it from the free edge side. So I would ask them if they have a phone, can I take a picture on their phone, not my phone, on their phone? And I use that like a mirror so that I can blow it up, show them the free edge side and say, look, when we're debriding, you can see all of these hollows and tunneling, and it's not tightly compact together. So as soon as we start debriding, we're going to hit these pockets and it's going to start to crumble and fall apart. So usually if there isn't buy-in after they see the picture, they go, oh, I get it. So that's just another little trick that I do.
Oh, interesting. I didn't think about it that way. I also remember that you really liked to take pictures throughout our study.
I took a lot of pictures.
Yeah, it takes time to know how to take a good picture, but yeah, there you are with enough light.
Well, it's so helpful to be able to show comparison of different cases and treatment outcomes. And there are a few questions about that as far as debridement. If someone doesn't want to proceed with a treatment, would you still debride the fungal nail?
So if the client, we had the conversation, and regardless of whether they decide to move forward with treating it or just they want to stay in a management phase, then the next conversation would be, do you want this debrided? Now, I probably wouldn't do it quite as aggressively, just so that I don't get any areas that might get hung up on socks but you got to remember too that in the early stages of treatment, so like this person here, we're seeing them, at least once a month, usually twice a month. And so they usually don't get to a point where they're getting those areas that would snag on socks or bed sheets or towels, because I'm seeing them too frequently that I can smooth all that out. But we would have the conversation as to whether or not they wanted to debride, and ultimately they make the decision. Their foot. They make the decision.
And then a question to follow up on that, are there any clear cases where you would not treat a fungal nail? There was a question here about someone on blood thinners, something like that, where you would say we're not able to treat this fungal nail.
I can't really think of any, not with this using ToeFX. I can't really think of any that I wouldn't treat. Certainly blood thinners wouldn't stop me because almost everybody's on them.
I was going to say that would really limit things. Yeah,
that would pretty much cut out everyone. So no. And you got to remember too that the thickened nail is also pressure on the nail head. So you can actually develop an ulcer underneath without the client even being aware that it's there, if you leave that thickened nail. So yeah, absolutely. And again, I would give that the pros and cons about doing it, and definitely, one risk that they would be taking by not debriding would be that if the nail gets so thick that they actually are causing an injury underneath the nail.
That's great. So another question, they keep coming in. There's a lot of questions. It's fantastic. So I'm trying to keep on top of these so we can get a lot of them covered here. Another one related to, so you've debrided the nail to treat it with ToeFX. You've obviously thinned the nail. Is there anything that you do or that can be done to protect the nail since it's been thinned and exposed while you're completing treatment?
No, I mean, I'm not sure if they're asking, can there be an unintentional nick when we're riding? Yes, that can happen. It is a risk. But that's
I
a
think it's
risk.
more about the possibility of there being additional trauma because the nail has been debrided.
Oh, yeah, no, not really, unless you leave sharp edges.
Okay.
This nail isn't 100% finished. So to Iret's comment of me liking taking pictures, well, apparently I forget to take my final picture. But no, not really. And if I was, I mean, I would just put a toe foam if they were concerned about it, because clients will say, oh, do I need to put a Band-Aid on this? Do I need to, you know, really, if they feel, if it makes them feel better to have a toe foam or something over top of it or a silicone cap, that's a problem. But normally, yeah, it's totally fine. And that's why, during treatment or after treatment, I'm always feeling with my hand. If there are any sharp bit, believe me, it will catch with the glove. And if you're really unsure, have a cotton ball handy and run it across. You'll know if there's any sharp edges or not. And again, if they're getting treatment, you're going to see them in probably 2 to 4 weeks anyways. Really not giving it a chance to sharpen up. And I think I'm surprised nobody's asked what burr to use. So I would for those streaking. So where we've got the streaking on this far side here, let's say I like tapers for going in there. So something that has more of a tapered shape to it, and how aggressive would really depend on how thin or thick their skin is and how much debriding. So that's kind of client dependent. And then just to finish all of this off, I would use something like a fine football or a ball burr, just to smooth out all those edges and make sure that I have nothing that's catching. Just because we've got this, shape that's kind of going like this.
Okay. Some of the questions that are here, I think we'll leave them for a Q&A section at the end of the webinar, but there was one final question related specifically to what we're talking about. If you're debriding and for some reason there's a bleed or something starts to happen, would you still proceed with a ToeFX application, or would you wait for it to heal before applying ToeFX?
That's a really good question. So Irit, what would you say with the applying a formula if there is a unintentional nick?
So depends. I don't recall that we had too many cases like that of bleeding because of debridement. So Tennis, maybe you can speak.
Yeah, I agree. I'm sitting here trying to think of a situation where I had that, and yeah, I don't know. Like, I don't want to say we're so good that we never nick people. Of course, we do nick people, not intentionally, but usually by the time we get down to this level, we're using a finer burr. We're not really using anything aggressive, and when you lighten up your pressure, the chance of nicking it is pretty slim. So I don't know. If there is an open area, Irit, is there any risk to using the formula? It's a really good question.
Yeah, so again, depends. If the bleeding doesn't stop, I wouldn't continue. But if it's a very minimal bleeding, so I don't see any issue with that.
Yeah.
Okay.
And I don't know, I'll just throw in there that I find Keltistat works really good. Just a little tiny piece. It'll stop it pretty darn quick.
Okay, that's great. So I think if there isn't anything more to add, written Tennis, I think we can move on to the next question. All right, let me just click back into here. Oop, too many forward there. So we did start to touch on this before, but this is a big piece of it too. When you're treating nail fungus, how do you set realistic expectations with your clients when you're proceeding with treatment, or when they've chosen to proceed with treatment?
Yeah, so I think this is a super important piece because prior to starting, first of all, it's part of nurses are to give pros and cons and make sure that a client is fully informed before we start anything. So this is a really important piece, but it also giving them realistic expectation just makes it a better experience for the client as well. And they're a part of it. And so we need to make sure that we really set those. So client realistic expectations for me would be that this isn't a one and done. Nothing with fungal infection, nothing is one and done. So it is going to take the full growth of a nail. So depending on the age and the health of the client, we're looking at close to a year, like probably I would say 9 to 18 months, depending on which nail it is. I'm talking about the hallux. Some of the other nails are definitely going to go a lot quicker than that. But this is the client has to be fully committed to showing up to their appointments. The realistic expectation that we got to debride this down, and they've got to be coming on schedule. And if they can do their homework, that is an added bonus. If we want success, we have to be a team. So they've got their part, we've got our part, and that there is no treatment for onychomycosis that is 100%. Like that's just, we cannot guarantee that they're going to be clear from this. But that's with any of them. And I think Irit, are you talking later about the results of the study that
Sure.
you guys found?
I have a few slides prepared for that, yes.
Okay, so I'll leave that part till then, but I think, letting the client, give them the information, give them the realistic expectations of this, that we're in this as a team, we're going to work at this together, but we cannot 100% guarantee that this is going to clear, but we're going to give it our best shot. If they're there, like we were saying earlier, they want to try, they want to give it a shot, and it really doesn't matter what treatment they're going to be trying, that's just realistic. And I would say the other piece to that too is reoccurrence. So the clients go, okay, well, if everything the nail after 9 or 12 months clears and it's looking really good, so that means I'll never have it again. Well, reoccurrence happens with any treatment, a certain percentage. I don't know, Irit may know better about that. Fungus is everywhere, and we can't guarantee that later in life that they're not going to have a reoccurrence for sure, and let the client make the decision on that.
Can you allow me, Jennifer, for a second to share my screen? So we conducted a clinical study, and we showed that 70% of the patient showed excellent to very good clearance of the nail. And here I wanted to talk about, sorry, I don't have it here. I have it on the other.
Tanis, well, Irit is getting set up. There was a question about the product that you mentioned. You made reference to a specific product that you use if you do nick someone.
Yes, Keltostat.
Okay, there was a question about that. Thank you.
Talking about reoccurrence, so we did recently a study with tennis where we wanted to look at how to try to use Toeflex treatment for maintenance, and basically to avoid reoccurrence of the fungus. So relapse rate are often are not discussed, and this is the elephant in the room, is between 20 to 50% of the cases are relapsed, and we really wanted to see how we can stop it or slow it down. So we looked at the 56 toenails, where we, after the duration course of the treatment, tennis show book the patients between 6 to 8 weeks. And actually we showed that 70% of them, the fungus didn't relapse and stay at bay. So actually TOFX technology can be used for two things, A, for treatment, and B, to avoid the relapse. So it can use for maintenance.
So, and I don't know if people know what, how effective some of the other products that are out there, but most of them, correct me if I'm wrong, but I think they're under 50% clearance.
Yeah, some of them are, yeah, around there.
Yeah, so you guys are sitting at 76 in the studies that you've done. And yeah, so that's, like, just to point out, that's really good results.
Yeah.
There was a question that came in through the Q&A about one of the lasers claiming to have an over 90% success rate. I'm wondering if either of you can speak to laser treatment.
So lasers, I never heard that it's 90%. About studies, often studies look at mild to moderate cases because the prognosis is for sure better. We started our first clinical study together with our dear COVID. And for that reason, we recruited mainly severe cases, and still we got really good results. So in that sense, it's superior to what is out there. About laser, the mode of action in laser is different than TOFX. TOFX works on photodisinfection. Laser kill the fungus by creating heat, especially most lasers, and it's more than 50 Celsius. So the clinician needs to stay in one point for enough time to actually burn or kill the fungus, and it's normally patients cannot tolerate it. So this is my answer about laser. I doubt if it's 90%. I don't recall that I ever read something like that.
And there's a great comment here about how one defines a cure. So it all depends on how the company has defined what cure means. So there there are so many questions coming in, but I think we'll move on to the next question here. I'll just share my screen quickly, just one moment. So, and again, it leads in exactly to what we were just talking about in terms of how can clients help increase the likelihood of success. So we've talked about the success rate of the treatment based on the studies that have been conducted, but how can the client themselves, and Tanis, you touched on this earlier, but how can they help increase the success rate?
Yeah, I think that we've actually kind of covered this. So I think I jumped ahead a little bit, and in that they have to be fully committed to this, showing up to the appointment, financially committed to this treatment as well, doing their homework. If we can get them to do that, it's great. But I think also looking at, for the likelihood of successful outcome, the clinician themselves has to be really great at prepping that nail, whether using debridement and application, proper application and use of TOFX. So I think that really, I think we've already sort of covered all of this for successful outcome. In my opinion, debridement, prepping that area, and application, and then the client's commitment.
Did you have anything else that you wanted to add there?
No, actually, I think Tanis covered everything.
Okay, perfect. There was one quick question related to the use of disinfection lights in shoes, and that in helping to eliminate the fungus from footwear. Is that something that you would recommend to clients?
I think it's a good idea, and I know a few clinics that use TOEFX, so they actually bought their own disinfected UV light, and while they treat the patients, they also treat their shoes. Me personally, I think that, but it's hard. The best solution is to convince the patient to get rid of their shoes. But
Yes.
people really like their shoes for some reason.
Yes, that can be a hard sell for sure. Okay, that's great. So moving on to the next question, research, and this is a big piece. And again, we've touched on this a bit already. Research that's available to support the use of using toenails to treat fungal toenails.
Yeah, actually, we talked about that. So we constantly doing clinical studies. The vision of TOEFX is actually to offer a whole complete solution to onychomycosis. So not only treatment, but also diagnostics. As we discussed before, if the diagnostics is not accurate, so the treatment might not work because it's not onychomycosis. So and we basically love research. I have a PhD in toxicology, and my business partner she has a PhD in physicist. Together we run the company, and we focus on research and improve, and always improving and finding new solutions.
That's great. And was there, you presented some of this, you talked about some of the study findings earlier. I don't know if we're going to go into a deeper dive into any of the research specifically today.
No, I could, but I think today is mainly to focus on the peer-to-peer
Perfect
discussion.
And I did skip past a question here. We did talk about a few other treatment options. I'm just going to see if I can go back here. And comparing TOEFX, a lot of the questions that are in the Q&A right now are related to other treatment options, whether it's tea tree oil through to obviously Jublia and other treatment options. How would you say TOEFX compares to these other treatment options that are available?
So I have a slide here. So you see my slide with the comparison?
Yes.
So I'm going to go from left to right. So there are basically 3 alternatives to treat onychomycosis. So it's topical. The most common one is Jublia. In the center is terbinafine, which is an oral medication, and then we talked about it, but it's laser. So as we said, debridement is very important, and often the penetration through the nail plate is lacking, especially when you're dealing with large molecule as in Jublia, because it just basically cannot penetrate the pores of the nail plate. Imagine the nail plate, the keratin is a protein and it's built in layers and in a very compact way to actually protect the nail bed from the environment. So what we did in TOEFX, the formula is very unique in a way that the molecule is very small. And we combined it with a vehicle that actually allow the formula to penetrate through the nail plate into the nail bed. The efficacy of Jublia is very low because it's a large molecule and it basically doesn't penetrate the nail plate. Another problem is because, as opposed to TOEFX, the patients everything is on them and they need to apply the formula twice a day for over a year. So older patients just cannot reach the toenails. Younger people, they are just quitting. They cannot, they're not going to apply twice a day for over a year. In terbinafine, the efficacy is higher. However, it might affect the liver toxicity and the liver enzymes, and people need to take blood work once a month. So it's basically treating systemically a local infection. So people normally shy away from that. And laser, A, it's very costly to the clinician. B, the mode of action is killing the fungus by creating heat, and it's causing some burning sensation to the patient. So these are more or less a glance into the alternatives to treat onychomycosis.
Thank you, Irit. Tanis, did you want to add anything there in terms of other treatment approaches that either you have had clients use or that you've used within your practice?
No, I think that there's lots of stuff out there, and people will be coming in with stuff that they're seeing on Pinterest and all over the place, or comments from neighbors or family members, but there's no research behind it, so I don't speak. I don't respond to stuff that there isn't research on. So yeah, I just don't make comment to some of those other treatments.
I wanted to add that often I hear from our partner clinics that people come to the clinic, they are very frustrated because they basically tried everything under the sun, especially that it's so accessible now to buy things off Amazon and get it the next day. So people try many things, such as tea tree oil is a good example. As a chemist, I know that this molecule, again, it's a very large molecule. It's not going to penetrate the nail. And also the efficacy in terms of antifungal and antimicrobial, it's not there yet, not there. So yeah, people try so many things. They're very desperate.
And there was a comment specifically about Jublia that in some cases the physician is only prescribing it to be used on the one nail that visually shows fungus, but not necessarily for the treatment of all of the nails, whereas ToeFX, you would be treating all of the nails. So yeah, it's definitely important to compare the different options available, educate your clients, have it backed up by research, so that you can have them make the best decision for how to move forward. So that's leading us into our next question, and it's about training and support that's available. We talked about research already, so we'll skip past that, but getting into the training specifically for ToeFX, what is available to ensure that practices and practitioners that choose to work with ToeFX have the training and support that they need to work effectively with the system?
So I will start, and maybe Tanis, then you can jump in. So we are offering a training. For now, it's free until the beginning of April. We feel that it's really important to do it right. The training is about an hour and a half. We go over the mode of action, the science, the basics of the treatment, the protocol, debridement, and things like that. And we really believe in providing constant support. So, for example, we offer e-tool, that it's image analysis that can, we have a software that actually traces the infection, and as a clinician, you can know what's the progress, and you can communicate it with the patient as well. We provide constant support on debridement, so we encourage our partner clinics to send us pictures after debridement and after applying ToeFX, just to make sure that they do it right. We have partnered recently with Tanis, We are very excited about that because we believe, I know that she's a very good educator and she's going to offer a TOEFX a training using a platform and a live support. So maybe Tanis, you can speak to that a bit.
Yeah, so I mean, we'd have it up and going now, but I'm super busy. We're launching an international course, so that's why there's a little bit of a delay. But I hope you guys caught that Irit said that it was free right now because it will not be in short order, but is very reasonably cost. So we're going to have an online component as well as how to debride the nail and prep the nail like we've been talking about for the last hour. Client expectations and tips on how to start that conversation with the client as well and integrate this into your business. We'll do a demonstration and then we'll have our return demonstration. So like Irit was saying, where you guys are sending information so that and photos so we can make sure that you're debriding it enough that the formula is applied correctly, the expectations with the client is reasonable. And so we're going to be doing that return demo live remotely. So you can be, if you're in the Lower Mainland and you want to attend, you can do that, or we're also doing it over Zoom. We've all gotten very good at that and sending photos so that we can zoom in and really have a really good look, and then on the spot, so right there say, no, let's debride that a little bit more and use these burrs, take it down, and then let's apply it, let's have another look. And you guys will also have access to the online theory component forever. So if you step away from your practice for a bit or you haven't done it for a little bit and you have a client coming in, you'll be able to do that review again and brush up and be able to provide your client with really good care.
There are a lot of new questions coming in now about training. Firstly, when, and you may have said this, I may have missed this while I was answering another question, when the new training platform will be up and running, approximately?
Oh, so hope is June.
Okay.
And if, you know, some people get a little bit nervous, don't be nervous. Like it's a very, positive learning environment, and we want you guys to be successful. So, but if you're a little nervous about the online piece, you can always pop on and there's a sampler course. I mean, it's different topics that are on there right now, but you can check out the sampler course just so you see how the delivery of material is on the peteducation.com website. So again, it's different content, but our goal, we're sort of shooting for June. But it doesn't mean that the training isn't going on right now. It's just going on differently with Irit, and it's free right now.
That's right. That's right. And that's an important point. Yeah.
Yeah,
Anyone who's looking,
point.
sorry, Tanis. Anyone that's looking to do the training before June, there is definitely still training available. So you can connect directly with TOEFX for that training until the platform is available. And as Tanis and Irit had said, that it is free until the platform launches. Is that correct, Irit? Correct me if I'm wrong.
It's going to be, we're going to charge in the beginning of April. So
okay.
Next
okay.
month or so it's going to be free, and we are going to send a follow-up email to this presentation with how to book the training.
Perfect. That's great. Yeah, anything that relates to training, starter package pricing, all of that, there will be information that will be sent out after the webinar. That wasn't pricing, and that wasn't something we were getting into specifically in this webinar, but we're happy, of course, to share that information with everyone and then keep everyone up to speed on when the new training platform will be available. So the message is, if you're looking to do TOEFX, you have 3 weeks or 2.5 weeks before the end of March to get the training at no cost, if that's something that you're interested in doing. Anything else? Oh, I jumped ahead one. Anything else that you wanted to mention specifically in regards to training?
No, unless people have questions for us.
Okay, I'm looking down to see, I think mostly it was about how to access it, cost and so forth. So that's information that we will send out after the webinar. And Tanis, for this is, I guess, speaking to the International Foot Care course, did you want to speak to that as well?
No, this is just what's occupied my time and why there's a delay between the two. So yeah, we're launching the international course, and then 100% of my time it will be then focused on finalizing the online platform for ToeFX.
Amazing. And so for this course as well, attendees, if they're interested in finding out more, can visit your website, and there's information on your website right now about the international course.
And I think there'll be lots of information going out when it's finally launched as well. I'll be keeping it updated. I'm sure ToeFX will be announcing the official launch as well.
Excellent. That's great. So then what I have here is a list of many questions, some of which have been answered. So if we wanted to move into the peer-to-peer discussion, certainly any questions related to the effectiveness of other treatment options or treatment options that don't have research to go along with them. We're not going to touch on that tonight or today, but I certainly will look through these questions, and please feel free to post anything else if there's a question that you're curious about. Certainly in terms of, there's a lot of questions about what do you charge a client for a ToeFX treatment and how many treatments are required. So I think it would be, even though that wasn't the purpose of tonight's webinar, maybe a quick touching base on that so that we can share that information.
So on average, the recommendation is to see the patient for the treatment a portion between 8 to 12 visits. So bi-weekly, every 2 weeks, between 8 to 12 times, and then to move to maintenance, so 6 to 8 weeks. In terms of charge, the average is about $100 per session, but there is between, I would say, 80 to 120. This is the range, more or less. There are often, sometimes the clinicians ask for a bit less, sometimes a bit more, but this is the range.
And in terms of approximate the number of treatments that would be recommended on average?
Average between 8 to 12.
8 to 12. Perfect. And there's questions going back to the discussion about debridement, dry technique versus wet technique when prepping the nail for a treatment like ToeFX. Is there a recommendation?
I always do dry. Dry is like when a client first books an appointment and I haven't seen their feet at all, regardless, I always tell them, because they want to help you. So they'll want to soak their feet, put lotion on, make them look as pretty as they possibly can for that first visit. And so I give specific instructions. Don't soak your feet, don't put lotion on 24 hours before you come to see me. I want them dry because I want to be able to control the debridement. So I explain it like wood. If you file wood when it's wet, it's a big mucky mess. The fibers are going back and forth. But if you do it dry, you can shape it into anything that you like. It's safer rather than sort of the tool being pulled in with, you know, if it's running at 20 or 30,000 RPMs, it's just going to get pulled into that soft soaked nail. So I always dry.
Absolutely. And from a supplier perspective, we obviously carry the vacuum integrated units, and we do get we do have the ability to bring in the spray units, and which are quite popular in Europe. But I couldn't agree more in terms of that ability to control the debridement with the vacuum is so much better. And so at this point, we've chosen as a company not to bring in the spray units, just because I do believe that it's a much better approach with the dry vacuum unit.
Mm-hmm. Well, you don't want anything wet if you have a vacuum unit anyways. I know you're talking about the spray.
Yeah, the spray wouldn't have a vacuum. The spray, yeah, that's right. There's no spray and vacuum.
No, but you don't want anything wet
No.
being taken up by the vacuum, because it's just gonna clog up your vacuum too.
Absolutely.
Super dry.
And the vacuum in itself is just not effective. The vacuum is effective with airborne dust. And so you need to create the dust in order for the vacuum to work effectively. And there's no better way to damage a unit than to, suction up any moisture. So, so great question there.
I also have a concern when using a wet drill. So the nail plate will be saturated with water or will be very wet, and it might block or eliminate the penetration of the formula. So it's something to just to be aware of.
Well, it's a good point, because it actually could have diluted it, I would think, as well.
Correct.
And then a couple of questions regarding PPE when dealing with toenail fungus. What type of, I probably answered this question myself, but that's okay. I will put it out there. What kind of mask are you wearing when you're doing treatment?
N95.
N95.
Always.
Yes. And then there was a question about, is there a risk with regular gloves of the practitioner getting exposure to the fungus through a glove? I don't think so. Is there any risk of the practitioner getting exposed to fungus through a regular nitrile glove?
I don't think so. No.
Okay, as I scroll down in these questions, ToeFX use on fingernails?
We haven't tested it on fingernails. However, it will work on fingernails. Yeah. And actually,
I did one.
Yes.
In the study, I had one fellow who had toenails and one fingernail. So I did 2 fingernails.
Yeah, and actually in fingernails, because they grow so much, they grow faster than the toenails, so the progress will be faster. We actually have few clinicians that are treating it right now on fingernails.
Okay, that's great. There are questions here as well related to, if you're not a nurse, are you permitted to use ToeFX?
So ToeFX can be used by foot care clinicians, not only nurses, also chiropractors and podiatrists, but so foot care nurses, podiatrists, and chiropractors.
Okay.
So
and with the new training module, is it required that they purchase the ToeFX system prior to participating in the training?
No, so the training will be at cost, as Jennifer said, the minimal cost, but when buying ToeFX after the training, the distributor Pedicare will give credits back to the clients. Right.
Yeah, so once the training is completed, and this will be communicated out as far as what the amount of that credit will be, when you're ready to purchase a starter kit, then yes, we will apply that credit to the purchase. Whereas at this point, you're getting the training at no cost, and so that is factored into the price of the starter kits, starter packages. This was initially a question in Quebec. In Quebec, podology is not a nurse or a doctor. Are we allowed to use the system as a podologist in Quebec?
Please contact me offline and we can discuss it.
Perfect. Let's see. So much great interaction. This is fantastic. I love that everyone is using this Q&A so actively. I think we've covered the bulk of the questions that we are covering today. Certainly there's quite a few questions, as I said, related to cost and purchasing. That's information that we can send out separately. If you're looking for information about training, you can reach out to Arit at ToeFX, Tanis, do you want, at this point, are you ready to be contacted, or would you rather?
No, I think if we could have them go to Arit until
Perfect.
we're ready, that would be great.
Okay, perfect. So any training questions, you can contact ToeFX. You can also contact Pedicare. We can provide you with information about the different starter packages and what that looks like, and then get you set up and provide you with the link to set up the training session as well. Arit, how long approximately do you spend doing the training online with new users?
It's about an hour and a half.
Okay.
Around an hour and a half, and then we follow up with pictures and throughout the treatment as needed. So,
That's
and we
great.
provide a certificate. So often the process after the training, we provide a certificate, and that allows you to buy ToeFX technology. Yeah, we feel that it's really important, and we are happy to provide it. It's really important to understand how it works and how to do it right in order to get maximum results.
And I think as well as practitioners start to integrate it and use it, that ongoing support piece is so essential. We have a couple of attendees on the webinar tonight who already have the system and have some specific questions that they want to reach out and get some feedback about as they continue to expand using it within their practice.
We have here someone that raised their hand. Should we?
Oh yes, let's take a look.
Winifred. So Winifred, I'm going to allow you to talk. Maybe, oh, no, yeah. 2 people.
Oh, we have 3 people raising their hands now.
Yeah.
Are you able to give them access, Arit?
Yeah, they can talk. Elizabeth, can you talk? Or you can ask us the question. Okay.
Great presentation so far, but I didn't really have a question. I just realized that my hand has been up all through.
So sorry?
No, I said great presentation so far. I didn't have a question. Just realized yeah.
Okay.
Thank you. There were a couple of the questions about just clarifying if ToeFX can only be used in a clinic setting or if it can also be used as a mobile treatment option.
Sorry, I was focusing on the hand raising. Can you just say
use the use of ToeFX in a clinic setting, or can it also be used as a mobile treatment option?
Yes, of course. It can be used in both. We have many clinicians that use it. Actually, many clinicians have a mobile practice as well as at clinic. So yes, it can be easily used in a mobile setting because it's portable. So the device itself is very light, is about 125 grams. And it's not bulky, so it's very easy to bring it from one place to the other.
And then questions about approval by Health Canada.
Yes, of course. ToeFX technology is class 2 medical device, and it's authorized by Health Canada for the treatment of onychomycosis.
And that's important with any fungal treatment that you're looking at, is to ensure that's a treatment that is approved. And Health Canada has become more strict about all fungal nail treatments. You may have noticed with certain topical creams and lotions, not treatments per se, but creams and lotions that used to claim that they were fungal treatments that can no longer make those types of claims without going through an approval process with Health Canada. So very important to make sure you're checking that when you're researching different treatment options. There are a number of questions here about burring, and our last webinar was much deeper into the burring and debridement side. So what we will do, I believe we can include a link to that previous webinar that does a bit of a deeper dive into burring, and of course, looking to educators like Tanis as well for education on burring. There are other sort of deeper burring education options available. But also we certainly can look at a webinar in the future where we talk maybe a little bit about burr selection. But in this specific webinar, we're not getting into the specific details of which burrs to use.
But by the way, Jennifer, maybe you can speak to that a bit. So with TOEFX package, there are, I forgot, but I think a couple of burrs that we recommended to be used for only for toenail fungus fungus nails.
Yes.
And through the treatment, we will emphasize about that a bit more.
Yes, and so with every package that is purchased, there are burrs that come with the package that can be used for debridement. When it comes to burrs, the selection is vast. There are so many to choose from, but we have narrowed it down to a few that are particularly useful when doing debridement for TOEFX. But certainly we're here to answer any questions that people have about burr selection and availability, but certainly, yes, looking at a variety of different diamond and carbide burrs that are recommended by practitioners like Tanis and other practitioners by TOEFX as well. Can you speak to your the foot care professional that works at your clinic, Arit, and their experience with debridement?
Yeah, we use so there are 3 types of burrs that we really like. I think we almost we over our time, but if you can I can show for a second how does it look like.
I mean, really, and the burrs that you would use for debridement generally within your practice for debriding thick nails are the same burrs that you would use to debride for TOEFX. Obviously, there are some specialty burrs like ball burrs that can be used as well within the nail prep for TOEFX. But again, that's something that would be covered during the training component for the system.
I mean, it's more than one burr as well. So you'd want to debride
Yes.
and then have a nice finishing one because now you're getting down to that nail bed and you have to be a little bit more careful. And so that's when you would go to the ball burr or the football or something that is a finer diamond just to do the finishing.
Were you able to find the slide?
I think it did pop
Okay.
up earlier, the one with the tying taper.
Okay, so these are probably Tanis can talk a bit about.
These are all great. I mean, anybody who knows me knows I love the tying and the NEM burrs. So yeah, they're both great. I would also add in the same, probably the tie-in with a taper for removing some of that streaking. And my personal preference as well. So the ball burr that's up there right now is a great ball burr, but if it was really delicate, thinner skin, they were on blood thinners like someone was talking about, and you were a little bit nervous about having an unintentional nick, I would probably do a ball burr, but I would probably do a diamond. That's just my personal.
Our clinician really like this ball burr to when he see how did you call it? Oil, I call it patches. It's the patches.
Yeah, the patches. Yeah,
the patches.
Yeah. So it's really easy or easier with these to dig into those lines and patches.
Yeah, I agree.
Yeah, and as Tanis was saying, the carbide one is a bit more aggressive. So starting with a diamond ball burr might be a good way to start out if you're not as familiar with the carbide burrs, just to ensure that you're not over debriding.
So it's skill set too, right?
sure.
So
Yes, it takes some practice. That's great. So I'm just going to put the final slide back up here. So there are a number of questions still here, some of which we can address when we send out follow-up after the webinar. But certainly if you have any other questions related to toe effects, the products, you can reach out to myself at Pedicare. You can reach out to toe effects directly. For education and training generally, please reach out to Tanis, but specifically the toe effects for now, please reach out to Arit. So Tanis can keep working away on her other courses and that she's developing. And we're just so grateful that everyone was able to join us this evening. We had a great turnout and love sharing this information. We could have gone in a few other different directions in the content that we covered. So I suspect there will be other webinars that take place. So please don't hesitate to reach out with any questions that you have. And if we haven't answered your question in the course of the webinar, please follow up with us directly and we'd be happy to discuss further. So thank you so much to Tanis, Arit, for coming out this evening, and for everyone across the country for taking part. We look forward to seeing you at a future webinar.
Thank you, Jennifer, for hosting it.
Oh, my pleasure. Thank you, everyone. Have a great evening.
thank you. Good night.
Good night.
Bye-bye.